We continue on with the skeleton now, and we're going to look at the appendicular skeleton. So the appendicular skeleton is essentially everything that we have not covered. And so we have the upper limbs, we have the lower limbs, and then we have the two girdles of the pectoral girdle and the pelvic girdle. And so essentially our attachment back to the axial skeleton. We can see here on the appendicular skeleton that we have essentially our arms and legs and the structures that connect them back to the axial skeleton there. And that makes up our appendicular skeleton itself. And so the pectoral girdle as well as the pelvic girdle. The pectoral girdle has kind of a weaker attachment back to the axial skeleton than that of the pelvic girdle. The pelvic girdle really has kind of the sacrum wedged down into the posterior side of the appendicular skeleton and the pelvis there. Whereas for the appendicular skeleton on the pectoral girdle, really all we have kind of connecting the entire arm back to the axial skeleton is this little joint here, the sternoclavicular joint, which is between the sternum and the clavicle there. Where the scapula is, this does not actually articulate per se with any bony structure of the axial skeleton. So the clavicle is a very important bone when it comes to the appendicular skeleton and its attachment back to the pectoral girdle itself. And we can see that in terms of the clavicle, the lateral side of the clavicle is actually kind of flattened out. So it has more of a flattened structure to it. And the medial side has more of a rounded side. And that relates back to its actual attachment to either bone on either side. On the medial side, it's connecting to the sternum. And on the lateral side, it's articulating there with the acromion of the scapula, which is likewise flattened. And so the two ends are going to kind of articulate with one another. And so they have to have a similar appearance between the two bones in order for them to articulate with one another. The clavicle, when we look at it, one of the things in terms of looking at an individual clavicle is to determine whether we have a right one or a left one. And so the flattened side is always the lateral side. And so the lateral side is pointing towards us in terms of the structure that's there. And then you have two big curves. And so the curves that are there within the bone itself there, the medial side is convex and the lateral side is concave. And so that can help us to figure out which side we're kind of looking at on that clavicle. The clavicle is important to the appendicular skeleton and the pectoral girdle here in that it is our one connection back to the axial skeleton. And so if we were to land on the outside of our shoulder here, so there's kind of the tissue line there, all of that force goes back through that clavicle and back over to the sternum. And so that's where it's going to take the brunt of all of that force, and it's one of the more common bones to actually fracture. And so we can see here that we have a nice fracture of the clavicle. So there's part of the bone there, and then we see the other part of the bone over here. And so nice little fracture there in the clavicle itself, and that allows for all of that force to be taken through that clavicle. And so it takes on all of that lateral force as we potentially land on our shoulder. The scapula is, or our shoulder blade, is a fairly complex bone as well. It has three separate fossa on it. And so we have three different depressions in the bone where we're going to put muscles eventually. And so we have the supraspinous fossa, the infraspinous fossa, and the subscapular fossa. And so that subscapular fossa essentially fills the entire anterior aspect of the clavicle. The supraspinous fossa is kind of an imaginary space that's just above the spine of the scapula. And then the infraspinous fossa is going to be filled in with muscle over here, everything below the spine itself. And so that's where we get the supraspinous, infraspinous component to the names that are there for those. And so with that, we have those depressions that are going to get filled in with bone. And then we have two structures that kind of stick out. One is the acromion. And so that acromion is going to articulate with the clavicle right here. And then we also have the coracoid process. So the acromion is an articular structure. The coracoid process is an attachment site for musculature. The socket component of our shoulder joint is just this little kind of shallow depression of the glenoid cavity. And so there's not a whole lot there to it, which is part of the reason why the shoulder has a tremendous amount of range of motion. The humerus also has some depressions in it as well, and so there are two fossa that we can find also. One is anterior here on the distal end, and the other one is posterior here on the distal end. And so we have the coronoid fossa and we have the olecranon fossa. Both of those are going to be utilized when we articulate the elbow in terms of our ulna. The head here, nice big round, almost looks like an entire globe as far as the bone goes, and that is where we're going to articulate at the shoulder joint itself. So that articulation that we have at the elbow has the ulna, and has this portion of the ulna here going into that coronoid fossa. And so it's going to articulate into the coronoid fossa when we bend our elbow. So when we do elbow flexion, that's going to go into that little depression that's there. When we do elbow extension, this portion of the ulna here is going to go into the posterior depression, our olecranon fossa. And so the portion of the bone that sticks up on the ulna is the olecranon process on there. And so those are both going to go in there. And since we can extend our elbow much greater, we have a much larger depression in the humerus to receive that bone. And that ulnar notch is actually on the radius. And so the ulnar notch is on the radius here. And it has that component there where the two are going to be able to articulate between the two. The radius also has the big radial tuberosity on it. And that big radial tuberosity is going to be where the biceps brachii muscle inserts into it and allows for us to do a lot of that elbow flexion that we want to do. Beyond the radius and the ulna, we come to the carpals. And so we have the carpals here as far as the wrist bones go. And there are 8 bones aligned in 2 rows. And so we have a proximal row of 4 bones, and then we have a distal row of 4 bones for those. The proximal row contains the scaphoid, the lumate, the triquetrum, and the pisiform. In this particular view, the pisiform is just barely seen there. That little tiny blip of a bump is the pisiform. At the distal end, always like to come back to the thumb side, and then we have the trapezium, which is next to the thumb. And then we have trapezoid, capitate, and hamate. And so those 4 bones go back across towards the pinky. When it comes to the carpals, there's many different mnemonics out there to be able to memorize them. There's a couple of links there that you can follow for looking at different mnemonics as well. And I've given you a couple there also. And the first letter of each of those words goes with the first letter of each of the carpal bones themselves that are there. The next row of bones, labeled with Roman numerals 1 through 5, we have the metacarpals. And so the metacarpals are kind of the palm of the hand, and then kind of the base of the thumb. And then from there we have the phalanges. And so we have a proximal, a middle, and a distal phalanx on digits 2 through 5. But on the first digit, our thumb, we only have a proximal and a distal. There's no middle phalanx there. Part of the reason why our thumb is shorter than the rest of our fingers. Moving down to the lower extremity, we now have our pelvis, and so this is now beginning the pelvic girdle, and the pelvic girdle itself is made up of the os coxa, or the pelvis itself, and then we have the sacrum, and then we have the coccyx on the posterior side. Here we can see the bones of the pelvis itself, and so we have the sacrum and the coccyx making up the posterior portion. We then have the os coxa, one side of the pelvis itself. This is actually made up of 3 bones, and so the kind of purplish color there is the ilium, the yellowish color is the ischium, and then the kind of reddish pinkish color there is the pubis, or the pubic bone. And that's there. We have one of each on either side, and that makes up the entire pelvic brim itself. So an os coxa, or the hip bone, that we have there is actually 3 bones that over our childhood and into early adulthood completely fuses together. And so it starts out as 3 individual bones, the ilium, the ischium, and the pubis. And then typically by about age 25 or so, the 3 have completely fused together. And so by the time you reach that age, depending upon kind of when your growth had kind of slowed down and everything, is going to dictate when that occurs. And here we can see the individual bones themselves once again on a skeletal specimen. And so we have the ilium, we have the ischium, and then we have the pubis. And so each one of those, and I drew it kind of like that to be able to see inside the acetabulum there. And so each one of them contributes a portion to the acetabulum. And so each one gives a little bit to the acetabulum, the actual socket joint that we have for the pelvis. And that helps to bring the bones together. The depth of that acetabulum is essentially being dictated by that of the femurs pushing up into them, but we don't want to start that process too early in life. We want the hips to be ready for weight bearing when the child is ready as well. When it comes to naming all the structures on the hip itself, I typically like to draw a particular spot to start with, and so I want to start at a portion, something like the anterior superior iliac spine, sometimes referred to as the ASIS, and then kind of work my way around the outside of the bone. We come along the iliac crest here, come back down to the posterior iliac spine, and then the posterior inferior iliac spine. We have the greater sciatic notch, the ischial spine, and then the ischial tuberosity, coming all the way around the pubic bone. And right in here, it's kind of hard to see, but we have the symphyseal surface, which is where the 2 bones are going to articulate with one another. And then we make our way back around. We come to the anterior inferior iliac spine, and we've now gone all the way around the pelvis itself with just the acetabulum and the obturator foramen, the hole here, left in terms of structures that you need to know. So the pelvic brim itself is essentially the opening that is there within the pelvis that we have. And so with that, we have a true pelvis and we have a false pelvis. And so the true pelvis that we refer to is essentially inside the pelvis itself. And so it's inferior to the pelvic brim itself. And so it's not just on the outer aspect, so to speak. This is all the way inside the pelvic cavity, and this is going to help to protect the pelvic organs. The false pelvis is above the pelvic brim, and so this has the sacral ala, this has the iliac bones, this is going to have some of the more inferior digestive, abdominal organs inside there. And this is the part that becomes wider in a female. And so the pelvis of a male versus a female are slightly different. And so that's going to change the structure between a male and a female as well. And so here we can see the false pelvis is that area that is right at the very top and follows kind of the top border of the pelvis, versus the true pelvis is down below and actually inside the pelvis itself. So when it comes to the differences between males and females, the two main aspects that I tend to look at are going to be the pubic angle and something that's not really shown on these ones because of the appearance that's there, but we can kind of just barely see it back here and here, and these would be the greater sciatic notches. So for the pubic angle, in a male, it's very narrow, and so it looks more like a V. If we were to flip those pelvi over, we'd see more of a V shape from the male, and in the female, we see more of a U. And so it's more of a U there, and in the male, it's more of a V between the two. As far as the greater sciatic notches are concerned, in the male, the greater sciatic notch is kind of narrow, and in the female, once again, it's broad. And so there's a lot more space in the greater sciatic notch. Those two structures tend to be very, very good at differentiating between male and female pelvis. The other ones can kind of sometimes fool you because not every person's pelvis kind of grew the same way. So that pelvis is going to articulate then with our thigh bone, the femur, and then the femur sits on top of the tibia. Next to the tibia, we have the fibula, and then the patella is central to the knee itself. And so here we have the femur, and femur has a big head once again, similar to that of the humerus. That sits on top of a neck. And then we see this big bump here out on the side. That's the greater trochanter. The greater trochanter is, if we were to kind of put our hands on our hips, usually they're going to rest right on top of the iliac crests. And then as we bring kind of our fingers forward along our hips, we're going to find the anterior superior iliac spines. And then if we just kind of push our hands down our hips a little bit, down towards the side of our thigh, you're going to come to another bump, and that's going to be those greater trochanters. And so those greater trochanters kind of stick out on the sides there. There is a lesser trochanter as well, so if we have a greater one, we got to have a lesser one. Running down along the posterior side of the femur, we have the gluteal tuberosity here. And then running along the length here, we have the linea aspera. So there's kind of a ridge there that runs along the back of the femur there. Down at the distal end of the femur, we pick up two condyles. And so we have our condyles here, and that's what's going to rest on the tibia. The patella is going to sit here something like this, sitting on top of there, and that's going to sit just in the patellar surface there on top of the femur when our leg is straightened. One of the other interesting aspects of the femoral head is this fovea. And so it's a little depression inside the head of the femur. And this is where we have our attachment for a ligament, artery, vein, nerve, lymphatics to get into that head of the femur. For the patella has an apex, and then it has a kind of a flattened base. The apex is pointed, and it actually points down. So the apex is actually on the inferior aspect. The base is on the superior aspect. And then on the posterior side, there are two facets. One here, one here. And that medial facet and the lateral facet are where they're going to ride along the femur itself. And so kind of as they rub against over the femur that's there. The lateral one is a little bit bigger and it's also kind of at a shallower angle. The medial one is at a more of a sharp angle. So if we were to look at it kind of how I drew it on the last one, we have a sharp angle and then it kind of flattens out as we look at it from the inferior aspect looking towards the superior aspect. And so this is our posterior side, this is our anterior side, and then we're going to have lateral and medial over here. The femur then sits on top of the tibia, and so we have the tibial condyles here, and that's where the femur is going to rest upon. Just off of those condyles, we have the tibial tuberosities, and so this is where the patellar tendon comes down and inserts into, so this is where our big quadricep muscles are pulling on for the tibia. If those get pulled on early on in life, kind of too much, we can end up having a condition called Osgood-Schlatter's. It's a common condition in kind of 9 to 13-year-old children when they're kind of overactive in their quadriceps muscles, and that can cause difficulty there for them as it kind of rips the bone away. The fibular head rests right up into the lateral condyle of the tibia and pushes up into it. Where the malleoli come down at the distal end, we have a medial malleolus on the tibia and a lateral malleolus on the fibula. And then our ankle bone, the talus, is going to come up right in here. And the two of them are going to kind of grab onto them. So those malleoli are, if you were to feel your ankle, those are what most people call kind of their ankle bones. And there we can see now the femur, the tibia, and the patella all together. And so as they combine with one another in an anatomical position there. And then we have the foot and ankle. And so the ankle now is called the tarsals. And so we have our ankle bones are the tarsals themselves that are there. And this time we have one less than what we had in the wrist. We now have 7 bones, and so we have the calcaneus, we have the talus, we have the navicular, and then there are 3 cuneiforms, and then a cuboid. And those are the tarsals. So the tarsals are near the toes. So instead of confusing the tarsals with the carpals, the tarsals are always near the toes of the body. We then once again have metatarsals right in there. 1, 2, 3, 4, 5. Just like with the fingers, we start at the thumb side for the fingers, and then the big toe side for the feet. The big toe being called the hallux. And so 1, 2, 3, 4, 5 metatarsals. And then once again, we have only a proximal and a distal phalanx on the first toe. And then we have a proximal, a middle, and a distal on toes 2 through 5 as we move along there. From the lateral view, we can look at the foot again as well. And so we have our calcaneus, talus, cuboid, 3 cuneiforms, can barely squeak in there and see them, the navicular, our metatarsals, and then our phalanges as they go along there. Those bones are held up on the side by arches, and so we have a medial arch and we have a longitudinal arch as well on those, and so a medial and a lateral longitudinal arch. Those run along the length of the foot, and then there's a transverse arch that comes across like so as well. And so when somebody talks about the arches of the foot, that's what we're talking about in terms of the foot itself. That's there, and depending upon how well the muscles and the ligaments are working in the bottom of the foot dictates how well the arches stay up. And we'll continue on from there.